Hello, guys. Can you hear me?
Now, yes, we can hear you and we can see you.
Excellent. So, you know, it's quite a complex case. We are going to explain you. And I have here my best team, Professor Stankov, Rossi, the nurse,
Yeah,
Sasho.
we need to see
technician.
see you in a full screen. Hopefully, there you are. Okay, that's good. That's good.
Okay, I'm already here, and Professor Stankov will. In fact, it's better to tell several words about the case, and Dr. Georgieva will present the case. Let's go, Dr. Georgieva.
Hello, everyone. This is Insito fenestration of aortic arc by extracorporeal femoral carotid bypass. Patient is RKN, date of birth of the 1st of April, 1915, age is 75. Diagnosed aortic desiccation, condition after graft implantation in the ascending aorta, integrant 28, surgical reconstruction of the left superficial femoral artery, December 2024, paroxysmal arterial fibrillation, necrofunctional class 1, chronic congestion heart failure, NIHA, class 2, arterial hypertension, third degree, concomitant disease, dyslipidemia, PAD, common carotid artery occluded, POD, gastric ulcer, anemia, CKD. 57 years old patient. He has admitted to the clinic for the first time due to a diagnosis the BEC type 1 aortic desiccation. The aortic desiccation was diagnosed in 2024 during hypertension crisis with BP value of 2040 over 1020 millimeters of mercury, accompanied by numbers and pain in the left arm. Then the patient was urgent hospitalized in the region hospital and CT scan was performed, ascending aortograph 21 and surgical reconstruction of the left superficial femoral artery was performed. Before the current hospitalization, the outpatient patient for CT aortocoronary CT aortography was performed with the following findings: persistent desiccation after the end of the graft, ascending abdominal aorta with the exit above the 10 millimeters above the bifurcation, a few entries of the level of the ostium of the truncus brachiocephalicus, dilatation of the initial descending aorta up to 50 millimeters. Recommendation for monitoring were given and a review was made for the further their behavior. Physical examination. Patient BMI is 25.61 kg over meter. On addition, he is a good general condition. The patient is hemodynamically stable with a heart rate of 57, clear heart murmurs with clear heart sounds without murmurs, and bone pressure of over 60 millimeter mercury on auscultation, vesicular breathing, in with isolated dry sins and chronic on the left hand base. Oxygen saturation in 95, ACG sinus rhythm, left electrolysis, 57 heart rate, PR interval 205 milliseconds.
Okay, let's shorten the things. You probably saw that I just positioned the lasso under the carotid. Could you show the CTs?
Yes.
Okay, you are now you are going to observe the CT, and in fact, the most important, probably new finding is that it resulted that the right carotid artery is occluded, with most probable reason for that is the compression of the true lumen by the false lumen that increased during the time after the operation, after the surgical operation. Next, please. Okay, you see how bigger is the false lumen compared to the true lumen. Next. And do we have a picture with the occluded carotid artery? Next, please.
Doppler sonography.
Okay, so we have this data by the duplex. So there are, of course, several challenges. Probably this one will be discussed after proceeding ahead. And now Dr. Stankov will tell you what was the progression of the case to this moment.
In this moment, we have 6 arterial approach: right radial, right axillary artery, left carotid artery, left brachial artery, left femoral artery, and venous approach for the pacemaker implantation for the rapid pacing during the implantation of the prosthesis. After take all this approach, we're going to go step by step. Yeah, we see here the huge false lumen on the brachial trunk and compression of the carotid common artery, like the Professor Petrov explained. We see it's to be very interesting after the centralization of the flow in the true lumen, what happened with the right carotid artery. And we back to the procedure. We now have implanted stent graft Valiant Captiva above the coronary artery.
Inside the surgical graft. So yeah, we are using, as I mentioned this morning, we are using the surgical graft as a secure landing zone for good sealing. And this is, you see the positioning of the stent graft with the nose cone inside the left ventricle. You probably, you see how the nose cone of the graft is protruding into the left ventricle, and the implantation of the stent graft is above, at least several centimeters above the coronaries, I mean the covered part, and the free flow is just at the level of the proximal part of the surgical graft.
Something very important, before the stent implantation, we prepare extracorporeal bypass ready for the start.
So you see the inflow by the femoral artery, and here you can probably observe the splitting of the flow here, in case the camera can show this, splitting the flow with intra-aortic balloon pump tubings, splitting the flow in two. One is going to the right axillary artery, and the other one is going to the left carotid artery. And as I have shown, in fact, this is the natural following the gradient, bypassing the blood from the femoral artery, going to the brain circulation. I will show you how interesting. Now I flushed the tubings, and you probably can observe how the blood is moving after splitting in two, is moving toward the tubings and going up to the brain. So definitely it works. It works, and we have proven many cases that the pressure that we are providing to the brachiocephalic vessels is around 70% of the systemic. And this is enough for the brain during the fenestration itself. You probably see that everything is totally percutaneous, so no surgical cut down. And Dr. Stankov will tell you he did the first fenestration, and we just implanted the first bridging stent to the left subclient.
Yeah, we have the very important position of the catheter in the two different projections. Сега ще дай ми в дясна, как го нагласихме. Върни назад. Yeah. We see in this projection, the catheter must be in the center of the stent graft to be sure the crossing in the stent graft. And the other projection, yeah. This is the crossing with catheter and electrified wire. We crossing from the prosthesis, the lasso waiting for take the wire.
Yeah, the snare is below, waiting the wire to come and to be catched and externalized. This is catching the wire, go, and this is the externalization. And after doing gradual stepwise predilation of the fabric of the graft. Go ahead, you are going to see several balloonings, and this is the externalization. You see, go ahead, balloon dilation, and
Next.
this is balloon dilation. So we are opening gradually, and we did a small trick here because we have true and true. So we have access by the left brachial and access by the femoral. We are performing all the balloonings and also the implantation of the graft from the femoral in order to push from inside to outside the fabric of the graft. Definitely it's more stable. Instead of pushing the stent from outside and to have the risk of invagination of the graft without crossing. So we have the femoral approach, and because the stent graft didn't cross immediately, we did this trick. So from the left, from the left brachial artery, we introduced over the same wire. From the left brachial artery, we inflated a bigger balloon, 8mm balloon, and following. This is the 8mm balloon you see coming from the brachial sheath, and this is following the inflation of the bigger balloon. We extracted the bigger balloon that is in the brachial, and with the stent graft we followed the balloon that were extracted during that time. So using the bigger hole that was performed by the and finally we implanted the stent graft. This is the implantation of the bridging stent graft, big graft, and now we are proceeding with the fenestration of the next vessel, the carotid. So we are going to position the catheter in two perpendicular projections to aim the fabric of the graft. I think it's not bad. Now we are going to connect the electrocautery. We are using the three-axial system. So we have the guiding catheter, the microcatheter inside the guiding catheter that is targeting the fabric, and the metallic wire. The metallic wire.
Okay, top.
Okay, you probably saw, register that. You probably saw the movement of the wire. We are now, most probably we are inside, definitely. It looks like, and we are going to check now if the lasso was, it was not. And with several movements, proximal distal, we are going to try to catch. Okay, probably now. Okay. Let's see right projection. We are checking now. Okay, if the wire is inside. Yeah, probably the wire is inside. Yeah, the projection. You see how important is the projection. In fact, because it's a right coronary catheter, it's steerable. You see, I'm moving now the tip of the right coronary catheter in order to hit just below of the tip of the wire. And okay, if it's not catched, no, but now it will be much more predictable. Go ahead.
Okay.
And not yet. I will move slightly more proximal. Okay, right proximal and distal. It's just a side, you see? Yeah. remove it slightly.
Yeah.
And I will
Wait here.
I will shift. Yeah.
Let's try now.
Okay. Okay,
Yeah.
we catch it. You see. And now it's the famous push-pull technique.
Such a fast.
So you push a little and I'm pulling and I'm pulling and I'm pulling and I'm pulling. And this is the externalization, the so-called famous true and true technique. So we are externalizing the wire. It's here. You probably can see the lasso, the snare, externalizing the wire. So now we are going to proceed with the fenestration from the femoral, as I explained already. Why from the femoral? In order to push over the fabric from inside to outside and not to invaginate it.
Добре.
Да, не е това. Добре. Ще го стреж ли? Okay. So now we are using the 014 wire for the small balloon in order to make a little increase of the hole. Do you have some comments or questions, guys?
Not at this point.
Okay. So we are going with a coronary balloon.
It's not easy from the stiff side.
Because it's we just cut the wire and we are in.
Саша, фас.
Тук имаме ли мъглен или?
Имам. Аз ще го пушвам така спокойно.
Дръж го здраво, даже го дърпай лекичко. Okay, you are going to see, okay, the balloon is over there, you probably see it.
Отиди в лява.
And we are going to change the projection for you to see how the balloon is crossing the fabric. Okay. At that moment, the balloon crossed the fabric of the chest of the Valiant Captivia. You saw our experience with Valiant Captivia during the years for all kinds of dissections. You can remove slightly the cutter. Very nice. Okay, I will inflate once again a little more. Exactly. And now the fabric is just in the middle, even over the middle of the balloon. So there is no doubt that we are across the fabric and we are fenestrating the fabric.
Now we can try the crossing with catheter. No,
it's too small.
Yeah.
We are going
with the next balloon.
Yeah.
After the next balloon.
We are going to dilate now with a 6 millimeter balloon after this small opening. Yeah, the pressure is stable, the ECG is excellent. So obviously cutting, please. Okay. Now it's much more predictable. Роси, като излезе го, не просто го стискаш, а даже леко го дръпваш. Я да видим, от тук имаме ли Мегдан?
1 милиметър.
Повече.
Отида на диплоп. Чакайте. с катетъра и ще ви дам още водача. Окей. Дай лъчи. Контра.
Дърпай. Дърпай повече.
Така.
It just crossed, the big balloon crossed, and we are going to do the same. With the nose of the balloon, we are going to open slightly, and after it, we are going to engage it. You see the waist of the balloon on the level of the fabric. За тук биграфта усмичка ли?
Не, десятка.
Супер. Значи трябва задължително да дилатираме хубаво.
Чакай сега да опитам да кросна с катетъра. Водача дръпни.
Дърпам го.
Дръпай. Okay,
you see, we crossed with the catheter, the fabric.
Сега ще следим сега надолу. Балона трябва...
Can you move?
Return the balloon or to be like the dilatator of the
Yes.
catheter. Go up, Sasha. Yeah. Дай надолу.
Yeah, this is the travel of the catheter from the carotid to the femoral. So we are going to externalize the catheter in order to have the possibility to change the wires and to put, go ahead, a little more here. Excellent. Go ahead. It's here.
Yeah.
We are ready. Now we are going to put a 0.35 wire on this true and true situation.
37.
And over the 0.35 we are going to proceed with the implantation of the bridging stent toward the left canal.
Да. I'm waiting for the wire here.
Yes. It's probably better to do the same. So to
with the balloon
open from above. Okay,
we can do it.
Okay, we can try. We are going to try to implant the stent graft now over the 0.35 with a very good support.
Дай ми инструментче.
In case it's not successful, we are going to apply the same trick like several minutes ago with ballooning from above and pushing the stent from below. Okay, this is, you see the big graft that I'm old school, always crimping a little more before implanting in order to be stable over the balloon.
Роси дръпни. Леко. Шеф поем вода.
We are going, we are going very slowly in order to see the behavior. But the problem is not only the orifice, but also the angle. It crossed. So we are, and the patient lucky.
Okay.
I think it's excellent.
Yeah.
Excellent position. You see there is a small protrusion. Exactly 2 rings of the stent are inside the aorta, and the rest of the rings are over the fabric. This is the stent graft implantation. You see, very nice. Very nice. 10 atmospheres. I think it's absolutely enough. And we can try, we can stay like this, or we can try just flaring like the new version of the, I mentioned yesterday, there is a new version of the B graft, the so-called B flare. And in order to avoid this post-ballooning, trumpeting, and other, let's say, terminology, but yeah, I'm just on the level of the fabric, and I'm trying now to inflate the part that is inside the aorta in order to have better sealing, like this. This is the homemade flaring. Homemade flaring, and yeah, we have already on the market the flared by the factory. Okay, good. Waiting a little the balloon to disinflate, and we are going to remove the balloon. Okay.
And start next fenestration.
We are going to start now with the brachiocephalic artery fenestration. You saw what is the procedure. In case not to interrupt the program, I would suggest to continue with one of the presentations, and when we have some progress in the case and something new to show, to be broadcasted.
Well, Ivo, I'm not sure we have any presentations left, but we haven't done a break. Perhaps we could do a short break and come back?
Yes, exactly. You can do a short break, take a cup of coffee, and probably in 10 minutes to show what is the progress of the case.
Sounds great. Okay, thank you. So let's go
Excellent.
for a 10-minute break.
Yeah, you see the right Judkins going.
We are ready with our case.
Okay, we are ready to just wait for us 1 second, but not wait, observe what we are going to do now. This is an injection into the aortic arch. Excellent. Excellent. Okay. Allow me to tell you what we have done since you interrupted the broadcasting. So, in fact, we succeeded from the first attempt in all the 3 vessels to cross the fabric of the graft. Next, very fast in order to reach to the 3rd one. Now I will show you the registration of the 3rd fenestration. Go. Yeah, one more. Okay, go one further. One more. Okay. Play. You see, this is the crossing now. At that moment, this is the crossing. Next, and you know this. Next, this is the externalization. Next. After ballooning, in this situation, because the brachiocephalic trunk is enormous, it's 16 millimeter. We did the trick with ballooning from above and pushing the stent graft from below. Next. Balloon in the orifice, and yes, this is the balloon. Next. Yeah, go back one. Go. Yeah, you see here we are trying to cross from below with the stent graft, but it was not possible. Next, and because of that we ballooned from above with a bigger balloon. And we followed the already enlarged orifice is following the stent graft. Next. We measured, by the way, after doing all these implantations, we stopped the bypass. You can see that there is no more, the tubings are not more there. The tubings are not more there, and we measured the pressure in the aorta. In fact, we can measure for you again. So You can see I'm taking in my hand is the side port of the introducer into the axillary artery, and after flushing I will show you what is the pressure. Okay, I'm flushing, and now I'm measuring the pressure into the right axillary artery. You see it's 120 into the axillary artery, and I will measure now the left carotid sheath. Okay, now this is the measurement, absolutely the same. Into the left carotid sheath 120. And now you are going to see the aortic pressure. Wash and measure. Okay. And this is the pressure into the ascending aorta. It's slightly above 120. It's probably 130. So it's a 10 millimeters of mercury difference, so it's practically nothing. And we are going to show you several pictures. One back, one, okay, go. Yeah, we inflated the balloon inside the stent graft in order to increase the size of the orifice toward the brachiocephalic trunk. This is a 40 millimeter balloon. Next. And you are going to see, next, we are going to see, yeah, this is in fact the injection after the bridging stopped. You see the excellent flow into the left subclavian and the left common carotid. And you remember that we shared with you that the right common carotid is occluded. It's confirmed. The right common carotid is occluded. Next. And one next. And we are going to see, in fact, you saw already this picture showing practically equal flow left and right. Obviously, the communication exists long time enough, and the brain provided flow is practically TC3, both sides, left and right. So the patient doesn't have any neurological symptoms during the late several months. So his brain circulation is definitely adapted. In case we go to the injection into the arch, go back to show the endoleak. In fact, we saw there is a very good result for the true lumen. You see how well expanded in the true lumen that was extremely compressed. But in the late phase, you are going to observe a small endoleak into the false lumen. And we saw where it's coming from. It's coming from the brachiocephalic trunk. And now we are going to prolong with an additional stent graft, the brachiocephalic trunk stent graft, in order to seal this endoleak. Yeah, it's type 3B. Okay, so questions, comments?
Congratulations for this excellent technical and complex cases. Everybody was very interesting. So at this stage, there is no question, only congratulations.
Thank you.
Thank you.
Thank you so much. We are finishing the case with this implantation and we are ready.
And we start to close
Before closing, yeah.
Yeah.
That is also sometimes it's a tough task to close the 6 arterial orifices.
During you finish, can we ask Kostak Victor
Yes,
to give his case?
Go ahead, and after Victor, we are going to be ready to to share our experience from here. So we are going to give
Thank
the
you.
lecture from here.
I would like to introduce Dr. Professor Victor Costage from l'Académie nationale française. Thank you very much. Are you as a technician?
Yeah, but I think I try my luck with the Renault if I may have one.
Speak to them. Can you speak in Bulgarian? No.